Wow. I love Mark almost every intro. You start with wow. And I love that. I just, because everyone, it's like,
There's a lot of good people out there, and we're getting to talk to them. And you
that's,
know what? Jen Johnson, our guest today, is another stellar guest.
yeah.
Like, you go into these things, you think about talking to people, and it's always a pleasant surprise to find out how much richer they are as a human being. And in this case, Jen is no exception.
Amen.
We are at the benefit of her wisdom, her insight, and we learn about so many subjects, right? She's written a book, Nursing Intuition, but it's so much more than what nursing is or what you might think of the show as. And I just encourage you, again, to stay all the way to the end because we ask our special question. But the last like 10 or 15 minutes turned out to be really, really rich. We learned a lot about the way Canadians perceive Americans in that part of the show. So definitely stick around for that, or fast forward if you have to. And subscribe and donate to Blast and to the Compton Cowboys. And remember that you make an important difference in the world every time you're kind and compassionate with someone you come in contact with. So we're looking forward to seeing you soon.
Sis, hallo?
11, 11, 11, 11.
Bestuur zeker wegen them.
Yo je iets niet, joh.
Sitaki ubenza, anika sirikie.
Two outlaws on the lam, taking the back roads through America.
You can't drink enough coffee for this show.
And now it's time for Monday Madness with the Moped Outlaws, Greg and Mark.
And we're live with another episode of the Moped Outlaws. Today, our guest is Jen Johnson, author of Nursing Intuition and the creator of the Nurse's Happy Place deck. And lots of other amazing stories I'm sure we'll get into. Welcome, Jen.
Thank you so much for having me, guys.
Yeah.
So curious, because on the site that I was looking at, it said the book was out on the 29th. Did it make it out?
Oh, no. I know. The editing process, unfortunately, is taking longer than anticipated. Welcome to self-publishing. Because if waiting 2.5 years for my traditional publisher and then to have them drop me wasn't bad enough, now to playing catch up and having to edit it, out of pocket kind of thing. But she's lovely and her work is fantastic. And this is just the universe trying to really get this last jab in to be like, we told you it's going to take time.
Yeah, and lots of good things do take time.
Yeah.
So tell us a little bit about what it is that inspired you to create this book. I mean, the title gives us a great insight, but what was it that really had you undertake such an amazing project?
Short answer is COVID and burnout.
COVID burnout. Okay, boredom.
Burnout. Yeah. So working at the bedside in the ER, my children were 4 and 5 when everything shut down the first time. And my husband was also essential. He's actually infection control. So he was working Monday to Friday, 8 to 4. Wow. And so then I had to work straight nights. So our schedule, or what was our schedule, was like 2 days on, 2 days off, 3 on, 2 off, like the Continental. And it was horrific. So I was just doing straight nights and living, 2 nights on, 2 nights off, 3 nights on, 2 nights off. And it just was awful. So getting no sleep whatsoever because my kids were up all day and I couldn't sleep and they weren't old enough to kind of leave to their own devices as I leave them to their own devices currently.
Well, they're 6 and 7 now. So.
They're 9 and 10 and a half almost. So
great.
COVID will be 5 years in March. Wow. Fun fact.
Wow.
Ugh, yeah, I'm over it. So over it. Yeah, just getting burnt out and not sleeping truly is what spurned everything.
No wonder it had.
Yeah, right. It's just me rambling, just going on and on and on.
No, that's not true. It actually, from the synopsis I read, it's actually a really powerful thing because health and well-being rests with nurses. Like having lived with an ICU nurse for 20 years of my life,
You poor bastard.
I understand this problem. She's between, you guys are between the patient family and them wanting to know everything and telling you what they think should be done. And then the communication pattern of the physicians who actually have the authority to prescribe and make sure that things are done, many of whom don't understand the day-to-day challenges that nurses face in this context. Now, you were in the ER, so that add like 3,000 pounds of time pressure on top of that.
And then some. So yeah, everybody, I mean, if you want to relate it back to COVID, the biggest difference with everywhere else in the ERs is by the time the patients got to a floor, you knew if they were positive or not. That was the difference. So everybody walking into the ER, you had no clue. And at the time, you know, day to day, the symptoms were changing and the risk, the screening factors were changing. The policies alone were changing day to afternoon to night. It was just complete and utter chaos. And so when the attorneys came forward and very kindly offered to do all the nurses' wills for free, you know, it really... We know that they had the best of intentions. But really the take-home message was, I'm not expected to survive.
Right.
Fantastic.
Wow.
So it left a lot of us where we were already kind of jumping and teetering between, oh, it's just the flu, it's not a big deal, to like, oh, people are really dying, to, oh, we're gonna die. Okay, this is bad. Like, this is
Well, but here you
not
are.
great. And here I am. I survived.
You know,
It was my mother-in-law who gave me COVID the first time.
oh, bless her heart. I'm wondering, I just saw this fantastic play, Angels in America. Are you familiar with it?
Is that the one where it's all healthcare workers?
No, it's
an off-Broadway?
it came out in the 90s and it was huge. And it had to do with the AIDS pandemic and closeted homosexuality and Mormonism. Anyway, but at the time, because I saw it when it first came out in the 90s, and the AIDS pandemic, what I remember that element of people are dying and there's no way to save them. And there was this sort of, it sounds like what you're describing you lived through is very similar. Is that the reality of the COVID pandemic at the beginning?
It's hard to say, because while the AIDS pandemic was happening and we hear about it, like we were taught a little bit about it, and you know, you read some things and you watch some shows, and again, you weren't quite there understanding fully, so you can't understand to live it. But for me, COVID, it was just this weird dichotomy of all of a sudden nobody's coming into the ER. We went from seeing 50 to 60 patients in a day down to like 10 to 12. And not only were these patients so much sicker than we were usually used to them being seen at, because they'd put off coming in for days and days and days because they were told to avoid the ER, and oh my God, they actually listened. Then it was the fact of just people being so thankful and banging the pots and pans and the thank yous and the free food and all the kudos. And you're like, so to be an ER nurse, you know, it's been 16 years now, and I have always equated being in the ER to kind of being in an abusive relationship with the public, in that the nurses are the victims. The public can get away with murder, damn near. And we kind of go with it, and we're like, okay, you know, let's talk about it and let's, you know, try and bring you back a bit. And if we get hit, you know, management's usually bringing us in to be like, well, what could you have done differently to prevent getting hit? And you're going, okay. So, you know, the onus is usually expecting people to be on their worst behavior. And so for everybody to suddenly switch and be so thankful and so appreciative, and nurses are heroes, which the heroes thing still kind of bugs me. It's just like, what is going on? Like, obviously this is much more major than we anticipated, because the public has changed. And that's when that really hit home, that this is a really, really big deal. And going to work and not knowing whether or not you'd get sick or come into contact with somebody who was sick, constantly worrying that you were going to bring it home to your kids. So my son's an asthmatic and worrying about him getting sick, or my husband, or heaven forbid, me giving it to another patient. It was just the fear and anxiety and the overall, the heaviness of everybody, right? It wasn't just us. It was the whole world was just so heavy and so worried, and it just trickled down to us. And so, but we kept on working. And so you got to see everybody do fun little TikToks at home and dance and be close to their families and hang out and do all these fun things. And we're like, we're just going to keep going to work. And we're going to strip we're going to strip on when we get home. And if the door hasn't closed for the garage, avert your eyes. You don't want to see this anyways. Like, you're stripping out of your clothes and carrying a different pair of shoes in your car, and not, having one car be the COVID car and one not be the COVID car. And, there were a lot of coworkers who sent their kids off to live with their loved ones because we were told in the beginning, it's just going to be 2 weeks. It's just 2 weeks. That's all it's going to be. And so, watching people send their kids away, and then, it just goes on and on and on. And so at what point do you bring the kids back? And then you have to worry about that. And for us, it was always, we actually had to sit down and have the conversation. Like, do you kind of withhold being as affectionate with the kids because you don't know if you've been exposed to anything? And we just made the decision that no, like, unless there was somebody who was highly suspicious of COVID, I was still going to love on my kids, and my kids are like stage 5 clingers. So there wasn't going to be, you weren't going to stop them anyways from climbing all over you. But there were so many decisions that had to be made around other people and their health that, you weren't used to at all.
So how does it feel to be back in the normal realm of just worrying about being bludgeoned and abused by the ER patients instead of COVID?
It feels like home. It honestly, it's the weirdest thing, but it feels normal. Like, it feels, you're more comfortable because people are starting to act up a bit, and they're starting to get lippy, and they're starting to whatever. And you're like, this is comfortable. This is what I know. This is how I know how to act with people. I don't know how to take a compliment. I don't know how to accept a thank you or free food. Well, that's not true. I know how to accept free food, but like, I don't know how to be appreciated, I guess, is probably the best way to put it. And it was just so weird that even people are still like, oh my God, thank you for being an ER nurse. I'm like, either I'm going to cry or I'm going to run off. I don't know how to handle this.
So what role is intuition playing in your life, and why is that important and an element of the book?
Yeah, so intuition, for any female over the age of 12, we all know intuition all too well. Books have kind of referred to it as the women's sixth sense, or just that gut feeling, when in reality we all have it. It's just women tend to be a little bit more in tune with it, only because it plays into our survival a lot. So if you go to a party and you get introduced to somebody, you're just like, creep factor. You go with it. You don't question it. You don't care. If your buddy's dating the guy and you're like, oh, dude, I got to talk to you later. You just go with it and you don't question it. So when it comes into nursing, and you're walking up the hall, and so I'm charge nurse fairly often. And so you kind of oversee all the other nurses and make sure that everything's happening. And you're kind of just coordinator, but you're also a resource. So when I'm walking up the hall and there's patients lined up in the hall, and there's somebody who looks like they're death warmed over, and you're just like, whoop, you're like, what is happening here? I need more of a story. I don't understand. Like, your color is not great. Your respirations aren't great. There's more to this. I need to understand what we're doing for this. Are we going full bore and we're going to do a resuscitation and everything else? Or is it a do not resuscitate where we're going to provide kind of comfort care and lean more into palliative care? I need to know what to anticipate here. So it's those moments where, you're handling a patient and they're telling you things, and it's like, well, there's more to this story. Like, I'm missing something. And truthfully, kind of operate on the fact that 90% of the people that I see on a daily basis are lying to me, whether it's by omission or they're overtly lying to me. You know, some people just can't remember their medications or can't remember what past medical histories they've got. So, you know, I'm missing things without realizing. And in order to cover my own behind, I like to not miss anything. So if there's something where this isn't hitting right, like there's more to this, I'm absolutely certain that I'm missing something. I will then go to my doc and say, hey, you know, this person's not great. I don't like the story. Their vitals are okay, but there's this feeling that, you know, something's not going to go the right way. And I don't know if they're going to code or if they're going to hit me, but like something's going to happen. I don't know. And so 9 times out of 10, you're usually on the right road. And those of us with experience in nursing, you know, usually greater than 7-8 years, we know this feeling. We all have talked about this feeling at 3 a.m. where it's, oh yeah, do you remember that guy from the other day? Yeah. I totally knew that he was going to crash because like something. And I'm like, there we go. That's intuition. But we just don't know, A, how to verbalize it without sounding completely nuts. And then B, bring it forward and be able to advocate the patient without, again, still sounding completely nuts, because it sounds like a very woo-woo topic kind of thing.
Yeah, that's very interesting, because it very practically speaking, I don't want, you know, me going sick and they go, well, I got this feeling that, like, I'm not here for your feelings. Yet,
you should be.
That's what I'm hearing, is actually we really should be taught and learn that feelings are an important part of healing.
Yeah.
So why is intuition central to your book?
So intuition is central because all of my big stories, everything that I wrote down, so the book originated from just being a trauma response and writing everything down in case I died for my kids to say, this is why mom continued to show up to work. And, you know, writing down the good stories, the bad stories came very quickly after, but it was this thread of intuition and trusting your gut that flowed throughout every single story. And whether or not I listened to it, whether or not I followed through, whether or not I told anybody else, whether or not I was believed, they all played out in different circumstances. And it was just that thought process of like, you know, the more I then opened up about it, the more other people would talk about it. And it turned out that it wasn't just a 3 a.m. conversation, because then I'd go to my ER docs and be like, hey, you know, when I come to you sometimes and I'm like, I just don't know, and I just want you to come see this person, and you do, why do you do that? And they're like, well, we know that you're good at your job and you've got a feeling about it, and we trust the feeling. I'm like, thank you. That's way more than I was anticipating on getting. And so trying to bring that, and then, you know, thinking about it. And when I wrote the book, it was like maybe September 2020. And I'm like, all the misinformation, disinformation was flying around. I'm like, unless I've got some seriously solid evidence to back me up, I can't bring this forward without theoretically risking my license. So I was like hemming and hawing, and ended up really doing a deep dive into things. And sure enough, there was just so much information on intuition, and like intuition versus insight versus, you know, the physiological versus the psychological. But then there was so much information on intuition in nursing very specifically. And I'm going, how are we not talking about it? There's like multiple studies over multiple years about all these different instances of nurses trusting their intuition and going with it. Why aren't we talking about it? And it's pretty much just because we all have this fear that it's a woo-woo topic, and we don't want to bring it forward to be the one to, you know, be the lamb roasted on the spit kind of thing. And here I am going like, I volunteer. Like, let me tell all my stories, bear all my trauma, and then be roasted alive for putting out this information.
The way I see intuition in the clinical setting is it's an invitation to do the investigation, to deepen the investigation, because the process of bringing a patient in, doing the analysis, and then coming up with a treatment plan has at its root a kind of assumptive diagnosis, but it's not always clear at that stage. You kind of have to go with kind of the probabilities. And then intuition, as that unfolds, becomes a curiosity to deepen the investigation and gather more data.
Yeah.
Right.
And I mean, what better than a puzzle for an ER nurse to solve, and the ER docs too. We all love a good puzzle.
Right.
How much do you advocate for a patient to be their own advocate of their health and trusting their gut intuition, and see the medical practitioners as informed elements to the final decision?
Yeah. I mean, patients, when somebody tells you and looks you in the eye and tells you that they're going to die, after dismissing it one time and then being proven really badly wrong, you tend to listen to the patients. You know, they know their bodies. I did the same thing when I was pregnant with my second. My first, we'd had cholestasis of pregnancy, and it was supposed to be really rare and all these other things. And the chances of me getting a second time were 70 to 90% if you had the same baby daddy. And so
what is cholestasis pregnancy?
So cholestasis is your liver and your gallbladder. So when they don't know if it's the physical weight of the pregnancy, the emotional weight of the pregnancy, the change in hormones, they don't know why it happens. But for some reason, being pregnant, your liver stops processing your bile salts. So they end up just kind of sifting down to your feet and just kind of hanging out there for weeks and weeks and weeks. And it's not until you get supremely itchy feet for over an hour every night, which was my symptom, before you kind of ask somebody about it. And because they say it's rare, but I feel like it's more, my gut's telling me that it's because it's such a benign symptom that all you really have is just itchy feet. Everybody kind of puts it off and, oh, it's just another weird pregnancy symptom, and they don't really follow up. But the risk is late-term stillbirth. And so with my first, we were 38 weeks. I went to the midwife. We're chit-chatting. It's been like a 45-minute long appointment. I'm just hanging out. And as I'm leaving, I say in passing, hey, do you happen to have anything for these like super itchy feet? I like up and itching for like an hour every night. It's driving me nuts. And she goes, shit, you were so textbook. I'm like, what do you mean was? She goes, oh, well, we just got to, rule out cholestasis and in pregnancy. And so we'll send you over to the maternal hospital. And so like an idiot, I Googled my symptoms and what cholestasis was on the way to the hospital, then realizing that the risk was late-term stillbirth, having a bird by the time I got up to the OB floor. By the time they checked my blood, my bile salts were already through the roof. And so the OB kind of said, we're inducing you this instant. I'm not going to sleep until we get this baby out kind of thing. I'm like, whoa. And everything happened very, very quickly. And so with my second, did a little bit of research. And I think so normally they don't find it until week like 32 to 36, just because of symptoms are so, whatever. By week 28, I was like, I'm not in pain, but something's wrong. I don't know what, but like something with this is wrong. And so I ended up going to the OB and having my blood work done, and my bile salts were already elevated at that point. And so I'm like, okay, well, there's that. Not a big deal. We're just going to do bi-weekly ultrasounds and weekly blood work that wasn't covered by OHIP. Right. So it was a full-time job managing the second pregnancy. But it was the very first time that myself, I knew something was wrong, but didn't really have any other evidence to back it up other than here's my history. And it's more than likely cholestasis again, because my husband was the same and, is what it was. So it was just, that was the first time that it was just like, oh, so patients can be feeling this where they know something's wrong, but it's so, it's not specific. They can't point to one area. It's not pain. It doesn't come and go. It's just this overall feeling that something's wrong. And it really made me take a second look at like how I'm treating patients and how I'm triaging patients, and just becoming more and more suspicious of anybody who's coming in.
Yeah. So what's up with hospital food? Like food is medicine. Why is it that so little attention gets paid to that? Like we know grandma's chicken soup has really important
healing
properties.
Process. Healing.
What
properties.
is it? Why can't institutions figure this out, that they need to really, really up the level of quality and food service in the hospitals?
It's the exact same reason why staff only is getting like quarter ply toilet paper. It's because it's a cost cutting. It's a very easy cost cut. Everything's boiled down to we're putting out propositions, and we're looking for input about who can come up with the cheapest meals possible en masse, and they're awful. Thankfully, labor and delivery was pretty decent, but I think they were the exception to the rule, because I see what people get in the ER, and it's, you've actually learned to like peel off the top lid before you bring it to the patient, so that the waft of whatever broccoli is in there doesn't hit them immediately and they want to throw up because they're already nauseous. So it's horrible. They need, they've got access to dietitians, they've got access to all these things, but it's a very easy cost cut, to be on the very blunt side.
Right. And then that brings us to this idea that one of the things that's even, let's just be clear, like we're in the US and you're in Canada. So you're working within the Canadian system, right?
Yes, I am.
Right. So
free healthcare for all.
Really? Yay.
That's what it is.
Yay. And, this isn't the only area in both the US system and the Canadian system where the priorities are upside down as it relates to health. Now, in our case, we can point to profit as the motive, but in Canada, the assumption is that profit's not isn't implicated. Is that true, or do we have it wrong?
No, it's just that there's only so much money to go around. So if all of a sudden you're paying for agency nurses, you're paying for new technology. My hospital, they're literally building a brand new hospital in behind me. There's only so much money to go around. So you end up being exceedingly, tight-lipped with everything, and you're just squeezing pennies until they bleed as best you can, because, you talk about raising taxes anymore, everybody flips out, rightfully so. But then you don't have the nurses to care for you. They can build all the beds that they want to, and Doug Ford can stand by empty beds all he wants to. Fun fact, there's just no nurses to staff them. He can buy all the beds he wants to. There's just no nurses.
So why is that? Why aren't more nurses coming through the programs?
More nurses are leaving than coming in is the problem. So the newest generation like Alpha or Honey Badger, they are phenomenal. They are not down for any kind of BS whatsoever. They are very quick to put their needs first, which is fantastic. So I ended up actually I spoke to Brock University, the first year nursing students. So September, like first year, first semester, first month, and all of their questions were, how do I prevent burnout? How do I avoid, falling into a depression? How do I manage work-life balance? How do I grieve a patient that I only knew for 30 minutes and they were dead the whole time? How do I do all these things? And all of their questions were about how to manage their mental health long-term so they can stay in the healthcare field long-term. And I truly said to them, I said, man, I wish I had better answers for you other than like alcohol and 2 therapists. Those are my coping mechanisms.
Well, but are they really?
Yes. Yeah.
Really? Wine and 2 therapists?
Wine and 2 therapists are my major. I have been on antidepressant medications during the height of COVID, which I'd never been on antidepressants before. But truly, like that's it. There is highlights of the job, and the key is to really find those, because they're small. They're minuscule little moments that, had you been too busy to manage, you wouldn't have noticed them. So the new nurses coming in, their new moments, it's like a baby's first, right? Like first time you put in an IV, first time you advocate for a patient, first time you're able to change a patient in a bed without them getting out. Like those are actually really big moments in a career, but we pass them by because we think that there's some other big life-saving bright win that's coming down the pipes. And sometimes it doesn't come down, if ever. It takes usually 5 years to get like one really big win where you're like, yeah, like we resuscitated that patient and they came out and they had no, long-term complications, and they came back a month later and they thanked us and they brought food. It was great. You don't get those. They're the, needle in a haystack kind of situation where if you can take comfort in, providing death care for a patient and have that be an understanding of a win, providing care and empathy for a family who's grieving, and you're trying to let them understand that it's okay to let go, and it's okay to get into the bed with grandma, because who was the last person to touch grandma? Like, when was the last time grandma had a hug? Like, who knows? Get in the bed. If they're dying, I don't care if you get in the stretcher. Please be with your loved one. Don't worry about the monitor. If you're paying too much attention to the monitor, I'm going to shut it off anyways. And I'm doing that because I like you and I want you to really enjoy this moment. But nursing school, you're going to save everybody. You're going to change the healthcare system. It's going to be great. Whereas in reality, that's not happening. You can't take the losses personally. You can't, live in certain scenarios and go over and over and over, because sometimes there is nothing you can do. They come in, they've already died. You're trying your best to resuscitate them, but really they're gone. There's nothing you can do. You're doing this to put in the effort, and you're doing it for the family, truly.
I have a question about the free healthcare, because you mentioned your blood work was not covered by
OHIP, the Ontario Hospital Plan. It was like the one blood work that wasn't covered. I don't know why.
So it's not 100% free healthcare.
No. So things like assistive devices. So if you come into the ER, you've busted your leg, you need crutches, you're going to pay for the crutches, you're going to pay for an air boot. We still pay for medications unless you have a benefits plan. You're still paying for your own dental and own eye care unless you're a child. I think children are covered. There are things that you're still going to pay for. Like if you just wanted, like I had a lump on my head that was bugging me, and I, went to the derm to get it removed. That was $700. I was like, whew, that was a lot of money for a very little bump. But that was my decision. So, I'd already waited 4 or 5 years to try and have a minute in Emerge where I could bug one of the ER docs to take it out for me, and it just never happened. So I'm like, it's only getting slightly larger. I'm just going to get it out.
One of the challenges here in the United States is for elderly people, and especially as they're approaching the last years of their life and need a lot of medical aid, and they don't have the money. Mm-hmm. Is free healthcare taking care of that challenge in Canada?
To a point. So if you're elderly, you're admitted to hospital with a medical issue, we've cleared up the medical issue, it's been a couple of weeks, you get up until 3 months after you've been cleared. if somebody's failure to cope kind of thing, you're not safe enough for us to send you home because you're going to fall, or you don't have the assistive devices to be, to allow you to be successful at home. We can't just like shove you out the door kind of thing, or we won't. So we end up, you can stay 3 months, and after that they deem you ALC, which is alternate level of care, which means you don't really need a hospital bed, but there's no other safe bed for you to go to. There's no retirement home that you can go to, because the retirement homes are very, very expensive. There's no long-term care beds to go to. So you end up just kind of hanging out in hospital for a year or two until a bed opens up somewhere. And so there is quite the push to keep people at home for as long as you can. We've got a paramedicine program right now that will visit you in your home, kind of keep an eye on you, make sure you're getting your meds and make sure your vitals are okay kind of thing. There's a palliative care team also with EMS that goes out, who are absolutely phenomenal. There's a lot of advances in keeping people at home, but sometimes once they come into hospital and they're not safe enough to send home, we're kind of stuck. And which is why you're waiting in the ER for a bed on the medical floor for anywhere from 100 to 180 hours, because there's just no movement, the funnel effect, and we're kind of at a pinch point.
Wow.
So it's not perfect. It's not
so
perfect by any means.
You're still practicing right now, right? Despite being an author and a lecturer.
Yeah, I'm still at the bedside. I can't. Everybody's like, oh, when are you going to leave? I'm like, honestly, I can't. Like, it's as much as it's a little bit of an ego thing. I really like what I do. And then I get to teach the new ones coming in, and we're struggling with having really decent people being able to teach the new nurses coming in. So I may only work part-time, but I'm happier. I'm able to balance. I do a little bit of agency nursing so that I actually get paid what I'm worth, which helps to fund everything and, fund writing a book and all the like. But I can't see leaving. I just can't. Not yet anyways.
So given the predilection for burnout, and the impact of particularly the ER, the ICU. I mean, it's like exponentially more complicated than some of the other places in the hospital to be a nurse, right? Just knowing what different drug interactions are happening in the moment and being able to keep track of that. But one of the things that occurs to me that might be really important is for someone like you to run for office before you're too burnt out. Because in order to shift the way the hospital runs, you need to be a powerful advocate, right? And know why the thing needs to change. So have you thought about that? Do nurses talk about what they could do to improve, the program from inside the bureaucracy?
We would love to. We truly would. But I mean, the problems that we have just from getting what the CEO, COO, the higher ups of the hospital systems, what they are going for and what we are dealing with at the ER level, having that be, change from level to level to level as you come down to your clinical manager. I mean, God bless my clinical manager. She's been an ER nurse her entire career and did ER education. So she came into the ER going like, we're going to clean this right up. And she has made phenomenal amounts of change. But then it's been, kind of turning where the manager is starting to creep in, where, the emails and the language in the emails is kind of starting to turn, and it's less, buddy to buddy, more like manager to subordinate kind of thing. Not to say that she's not still absolutely amazing, but, just watching that change in somebody who was so for the ER, I'm a realist and I understand what politics are all about. And to be very honest, knowing my history and what kind of things could come out of the closet in my own previous history that, I've openly talked about, I probably would be pretty well sunk within the first week if I tried. And I don't have the tolerance for it. It's the same reason why they don't want nurses on jury selection, is because we're very black and white. Once we make up our mind, there's no going back, and it takes a lot to change. And so, I would love, I would love if anybody from, our side of the field kind of came into healthcare and actually experienced healthcare as everybody else does, not as a VIP. I would give all the money in the world to see Doug Ford as a patient and be treated as a normal human being, and have to wait to see a doctor and have to wait, hours and hours and hours and hours and hours to get a bed and onto the floor, and to see what we're dealing with on a daily basis, and to have to be up all night because of the dinging of the monitors and the person yelling next to you, and, hear us, be threatened and all these things. I would give anything to have somebody in politics come and work a 12-hour night shift on a full moon, and or a long weekend in a, urban scenario. I think anybody who's working healthcare who's not directly at the bedside needs to be doing that at least once every 6 months, so you can keep some perspective, because once you leave the bedside, you lose that day-to-day in and out of what's going on and how we're actually treated, and what actually goes on in a day. Because, it's very easy to pick apart somebody's care when you're just looking at one chart and you're going through the timelines. Oh, it's been 2 hours since you charted on them and you haven't done vitals in 4 hours. And oh my God, what's happening here? And you're like, yeah, but the rest of the department was on fire. We were 2 nurses short. We had a vital signs absent, so we were having to do a code. We then got them back. Congratulations. But now we have to transfer them out. And a nurse has to go to transfer the patient out to a tertiary care center because we don't keep vented patients. And dealing with things like that and pushback from other sites about us dropping off patients there. So you miss a lot of what actually transpires in the day-to-day. And, kudos to my manager for still coming up very often and occasionally triaging, actually, which is one of the hardest jobs. So kudos to her. Yeah. But, she's lived it her entire career. So of course she's going to gravitate towards it versus, putting a respiratory therapist as a manager of an ER who's never worked in emerge, it's its own beast. You can't compare it to any other department, and other than like potentially maybe like an outpatient kind of scenario, because people are just coming and going and you don't know if they're staying or they're going.
With your real world experiences, what's your outlook on death? What's your experience with death?
Death needs to be embraced. Death is going to come for us all. And, you know, somebody once asked me, if you could have anything happen in the world medically, you know, what would you do, or what would you ask for? And I said, honestly, to have do not resuscitate conversations, or, you know, life-saving conversations happening at 55 about, you know, whenever you're going for your yearly physical, if you want to then talk to your doctor about, you know, hey, I was reading this article or I saw a show where they actually portrayed, you know, chest compressions. And I really did look into it, you know, what chest compressions actually entail. And I didn't realize that they were going to break all my ribs. And, you know, even if I came out of it, I potentially would come out with a punctured lung or bleeding or any of these other things. To be having very frank and open and honest conversations with people about death can be very liberating, but unfortunately they don't usually happen until somebody's already 1 foot in. And then it's like, are we trying to save them? Are we not trying to save them? Are we like, where are we landing? And some people think that it's like a pick and choose where, well, I want them to be intubated, but I don't want chest compressions. And you're like, it's kind of a package deal. You know, if we're intubating them and their heart stops, they're still going to die if we're not going to do chest compressions. So, you know, there is lines between palliative care, and it doesn't mean we're still not treating. So if somebody's in palliative care, you know, they've got a chronic illness and they get a urinary tract infection. Well, we can give you antibiotics for the urinary tract infection. That's no big deal. Like we're still going to treat you. It's just that, you know, when it comes down to life-saving interventions, that's where we're going to kind of call the line.
Yeah, my experience with the medical world, real quick, Mark, is it seems like the people, like nurses, are primarily working for a person's comfort when they're in the process of passing away.
Yeah. And there's so much we can do. There's so much. You know, it doesn't need to be scary or freaking out or painful. I mean, the amount of medications that when somebody is finally admitted into kind of palliative care and they get that order set going, like I can keep them comfortable and pain-free. Are they going to be alert? Probably not, but they're going to be comfortable. And it gives you guys time to kind of come to terms with that and, you know, talk with the person, get in bed with the person, figure out what decade they were like 20 to 25 in, and go on iTunes and get playing a top list from that decade. And so it's the same thing we did with my grandmother. And, you know, I very much with my mother, I was like, do not resuscitate, right? Like she's 96, let the poor woman go. And, you know, when we got there and I'd seen her, and it's been a long time since I'd seen her with COVID and everything, I'm like, oh, she kind of looks like crap, but yeah, she's kind of getting there. And so I got in the bed with her and I played Frank Sinatra, and I played My Way. And I didn't realize at the time the lyrics of My Way are not great.
They're great. They're fantastic.
I was playing it and I'm like, oh my God, please do not let my mother hear this right now, because it's like, and now that the end is near, the time for the final curtain. And I'm like, oh my God, this is the first song that comes on. And I start laughing because it's just like my grandmother to pull this kind of crap and mess with us all, because that's just her. Well, you know, she was kind of comatose, not really responsive. She starts tapping her toes. And my mother's like, I would have never in a million years thought to do that. I'm like, absolutely. I'm like, she's palliative. The whole room is palliative. Let's just play some music and just like, you know, death doesn't need to be scary. It can be honestly, truly beautiful and very fulfilling in knowing that someone's gone peacefully and surrounded by family, and everybody can laugh and visit whenever they want to, and they don't have to be quiet kind of thing, versus being admitted to an ICU after a resuscitation and their visiting hours and have to be quiet and all the dinging and the lines so you can't get into the bed. It's just two very, very different worlds that, you know, you have the option of choosing which one.
Well, and one of the experiential things I had as a result of being in a relationship with an ICU nurse was her observation that so much of the communal resources that go into running a hospital get consumed by the emphasis on life-saving at points where it really is just a waste of cash and a waste of everybody's energy. So that's both cultural and institutional in my viewpoint. Like if we as the family aren't constantly like, well, can't you give him a heart transplant? And like, right? Like blah, blah, blah. So if we actually solve the problem that you're talking about through both the cultural part where we're just like, yeah, he's 60. It's okay. Right. Yeah. And I'm 61, by the way.
To be fair, 60 is quite young. We call that quite young.
Great. I'm glad to hear it. But the point I'm making is that type of care is also very expensive to administer and consumes a lot of resources that we could be putting into actually giving people steak and fresh broccoli.
Yeah. and truly, let alone the other thing. So I can't do ICU. I am not an ICU nurse. I'm too ADHD. I'm not OCD enough for this. There are, straightening up the lines. I could care less. And God bless you for being with an ICU nurse for that long. Love the ER. But it's the ethical burnout that also we do not talk about, the fact of keeping people alive way past when they should have gone and having conversations with families and the families completely shutting them down. And yes, the resources to that end, but you want to talk about another aspect of burnout. Well, there's the ethical and moral burnout from watching somebody waste away to nothing, have bed sores all over, you can see or put your fist into their buttocks because it's down to the spine. It's horrific. And being able to do absolutely nothing about it, but the family expects you to keep on going and keep giving them their tube feed and all these kind of things. It's just, the expectations are ridiculous.
Wow. We've like the whole, that was Halloween, man. Like putting the person,
the healthcare system,
right?
Let them go,
right? If we just let ourselves go
comfortably, respectfully,
right? Less resources get consumed in ways that aren't helpful.
And in Mark's words, you can have fresh steak and fresh broccoli.
Fresh steak. Listen, I bet you if you pitched it to people that way.
Good point.
It might work. I don't know.
Run for office.
You go for office. Exactly. You go for office. You do.
Okay.
You go.
Make me emperor of Canada and the U.S. and I got you guys covered.
We're gonna cut off the U.S. part. It'll just be emperor of Canada. It's fine.
Okay. Which brings me to this point of how is it for you to witness what we're going through in this political season?
What do our neighbors think of us? How did the frat house move in next door? What happened?
So there's a lot of popcorn consumption. The TikToks are crazy. So it was just actually down in Vegas and for a health conference. What is it? Popcorn.
Good popcorn too. Maple.
Well done, sir. Well done. It's really, really sad, and we're really worried, and so is the rest of the world. And maybe it's just the TikToks that I'm being fed, and the whole all this kind of stuff.
Algorithm.
But the algorithm, it seemed like things were just not a problem. And then I went to Vegas for Health, which was this massive health conference held at the Venetian, and went to a Jeff Durham concert show. So he's a ventriloquist with the puppets. Super funny guy. I've been following him for years. Love his stuff. And again, as an ER nurse, super crass, super off the cuff. I get it. I'm down for it. And so we go to get seated and I'm in like golden circle. I'm like 4 rows back. I'm like, yes, this is awesome. There's a lady comes in with a Trump jersey and it's bedazzled and she's got the little Make America Great Again. And I start taking photos because I'm like, oh my God, there's one in the wild. Oh my God, they exist. Oh my God. And send the photos back home because of course we're all laughing. And Jeff gets up there and he's like starting his stuff. He's like, actually, guys, just gonna take a temperature feel. He goes, who's voting for Kamala? I'm like, we're going. And then he's like, who's voting for Trump? And the place lit up. And I'm like, I want to walk out right now. I don't care about the rest of the show. I am so uncomfortable. Now I'm fearing for my life. Holy crap. Oh my God. And it wasn't until that moment that I thought that it was even a possibility. Because I thought you guys had learned your lesson the first time.
So funny, like you're in this quiet prairie and you go, oh, look, a wild animal. That's so cute. You suddenly realize they're everywhere.
I'm surrounded. Oh my God. And he keeps, and it wasn't just that, like, there was that portion to it. And he kind of kept going back to it. He kept saying something about, I don't know what he was saying. He was making some dig at Kamala and I didn't get it because apparently I'm not on that side of TikTok. But he then kept like trying to like hawk his wife's cookie batter, which great for you for supporting your wife, but like it's a comedy show, dude. Like, and then stopping to like, oh, and this is my new puppet, and then going again. I'm like, I feel really like I kind of feel like I watched something on TV where I had to sit through commercials, like like I felt bad, and the whole time I'm like, do I leave? Do I not? It was, but I was like right there. So I was like, I'm just asking for it if I stand up and leave because you can absolutely see everything that I'm wearing right now. So I'm like,
what were you wearing? Were you wearing pro Kamala stuff?
No, pro Trudeau.
Got it. So we're taping this the last show for the Moped Outlaws before the United States election, and this is going to air the day before.
Oh God.
On Monday, the election, and you're very concerned that the Republican Party is going to win.
What
is that the case? Is that what I'm hearing?
Yes, Trump. Like, as a female, I couldn't figure it out the first time around. As you know, somebody with 2 brain cells in my head, I still can't figure it out. This is probably going to get me sunk and canceled and all the things, but like, the guy's been convicted of like 32 felony counts. Like, the reason why it's not in the Constitution, guys, is because nobody could have pictured 200 years ago that anybody would be in this position of power that could even have come close to being convicted of these felonies. That's why it's not in the Constitution.
Well, let me ask you with your intuition, because you just mentioned how the bedazzled woman you saw was a woman. Well, we don't know for sure. We didn't ask her pronouns, but
we did not. But she's fairly female presenting.
But there are a lot of women I see that support him, and a lot of people of color that support him. And I'm wondering, intuitively, what do you think is going on in our country, the United States, that is creating these choices? Potentially, of course.
Honestly, when I saw her, I kind of my gut feeling was to pull her aside and be like, are you okay? Like, what kind of trauma have you had in your life? Are you in an abusive relationship where this is the guy's whole stance and he's kind of beating it into you and this is just what you've subconsciously picked up? Is it family values? Like, I don't know. But honestly, my gut feeling was I was worried for her because I don't understand how you're not putting 2 and 2 together. Do I get that, the algorithm figures you out? So once you kind of lean towards one side or the other, that's the way it's going to take you. And so same with the COVID misinformation, disinformation. I mean, those people, like they really got under my skin. They, for them to come in and demand care, but then very aggressively throw in my face that, what I was doing was fake and not real and and all these things. You got real angry real fast, which is why we were all drinking. But it was just like, what side of the world are you on where this is news and reliable and factual for you? I mean, I can fall into a good like a oh my God, a theory. I can fall in. Listen, aliens, why not? I can fall into them just as well as the next person, given the right direction and information and all that. But at a point, when, oh my God, just the federal convictions alone, like I don't understand.
Well, I think for that
the
part,
majority of Canadians share your opinion. Is there like a unify, or do you think there's a level of division that's part of the Canadian landscape as well?
Oh, there's definitely a level of divide also. So when you guys had January 6th, the truckers, when Trudeau wanted to mandate vaccination for truckers, that did not go over well. And so the truckers, a lot of them, actually a ton of them, came to Ottawa, parked their rigs in front of Parliament and just shut it down. And they were exceedingly disrespectful. They honked their horns. So anybody living in that area, they honked their horns constantly for weeks. Nobody could get any sleep. If you had young kids, forget about it. You weren't getting anywhere. People who were stuck when it all happened originally, they wouldn't let anybody move out of being stuck. So there were diabetics who were like falling into crisis. That there were some WhatsApp chats that kind of surfaced that, the people were like, well, that was his decision to be in this. We warned you guys, blah, blah, blah. And you're like, do you have no common decency to understand that this may not be their viewpoint, but just because they're in the wrong place at the wrong time, they should potentially be affected lethally? I don't understand. And then the fact that they continued to carry on and carry on and carry on. And then they set up hot tubs. Nothing says my rights and freedoms are being taken away like setting up a hot tub in front of Parliament.
So you mentioned this issue of mandates of vaccines.
Yes.
I want to ask you the question about whether, as a nurse and as a human being, you think that is reasonable for the government to mandate that we take something into our bodies and that we are not able to exercise our bodily autonomy.
How do you feel about women and their bodily autonomy, Mark?
Well, I'm pro-choice for women.
Sorry, I'm just devil's advocate.
I'm super clear. I want women to be able to make the decision. I would like it if it was done with the partner involved.
Absolutely.
Optimally, but at the end of the day, it's their right. It's their body.
Yeah. So for me, when, everything happened and the Canadian government, granted, was very strong with their standpoint and, shutting down the borders and the isolations and the mandates and staying isolated for 10, 14 days originally. I mean, they really cracked down, and truly we did not see the deaths that the US did. And granted, you guys have got the population, is what it is, but we did not see near the devastation to even a percentage of what you guys saw. And so they did crack down very hard. Do I think that the government should be mandating something that's in an individual choice? No. Do I think that as a healthcare provider, being in contact with people who have no immune systems whatsoever, as a part of my job, I'm already mandated by the healthcare system that I'm working for to have all of these other vaccinations? Yes, I do. That's where I kind of draw the line. Do I understand that some people will have, reactions to it? Some people are under chemotherapy or immunotherapy where there was kind of I don't know if I should be taking this because it is so new. Absolutely. People with kids or people who are worried about their fertility, could I understand their hesitance? Absolutely. But it was the people who got in my face about, and again, usually middle-aged white men, got in my face about not having the vaccination and not needing to, and not, thank you. and getting in my face and being just aggressive and very obviously looking for a fight. That's truly all they were looking for, whether it was going to be about a vaccination status or about an isolation status or about what testing we would do. They just wanted to fight. And so
before you go, Greg, I want to get to the actual heart of my question.
Uh-oh.
Yes or no? Do you believe that when the government decides it's important, that a vaccine mandate is a legitimate thing that people should comply with?
I think that there's a part of me that wants to say yes because of everything that happened and because it really was protecting everybody else. There's a part of me that wants to say no because it is bodily autonomy, and everybody's in a different spot where with their health and their mental wellness and all this kind of stuff. Should they have dictated it again to those in the helping professions, to those exposed to the elderly and people with chemo, children's hospitals? Yes, I think those people should have been vaccinated.
You know what, though? It's not just individual body autonomy, because you aren't allowed to drive drunk because you might kill someone.
It's a very different standard, though, Greg.
How?
Because no one asked me to get drunk. No one made sure that I had to get drunk.
No, what I'm saying is the law is saying you can't get drunk and drive because you might kill someone. Well, then they said, you got to take this because it's saving lives, not just your life. It's saving
others'
lives.
Okay.
It's a hard line to fall on.
I love that expression. And my point in asking this question is that I think it brings us into a discussion about healthcare, which is about individual care plans and choice, which ties into this idea of when can someone ask for palliative care without it causing a lawsuit, right? Or right? There's a lot of gray areas here, and I think that vaccine mandates, when you start to talk about them as a subset of the population in areas of employment where you are high level contact with others, I can see the argument.
Yeah.
But for the guys living out in the middle of, the forest when they're cabins, right? I don't see the argument there.
It was hard. So in talking to people, and we asked for a long time if people were vaccinated, and really it started so many more fights and so much more friction than anything else. And truly, did it matter? No. If you were fevered, if you were short of breath, if you were doing all these things, you were still going to be isolated. It didn't matter whether or not you had your vaccination or not, but it did give us a little bit more of an idea as to how severely do we need to act? If you're unvaccinated and now you've got COVID, oh man, we're going to worst case scenario in 10 seconds flat, versus you've had 2 to 5 doses. Okay, maybe we can be a little bit gentler with what we're coming at you with versus hitting you with the Mack truck.
Got it. This is such a frank discussion. I just want to honor you for your courage in the way that you show up in this conversation and your willingness, while also making jokes about other things. I think that's brilliant. And in some way, that's a survival mechanism for people in your profession, right?
1000%.
So maybe instead of politicians, we could graduate you guys into being comedians.
Yeah.
Listen, have you followed Nurse John? Have you followed the Nurse Daddies? Oh my God, Nurse Blake, you are missing out on
Nurse Blake, Nurse John, the Nurse Daddies.
The Nurse Daddies. Oh my God,
for good comedy.
Oh my God. So Nurse Blake and Nurse John are actually on tour right now, going through the States. I can't remember. Nurse John was just in LA, and I think that he was heading out, Florida maybe. But he's Canadian, and he, worked the floor, and he was a clinical educator, or not a clinical educator. He was a clinical instructor for students and all the like. And his stuff is just so funny because he comes in and dresses up as a female, and he's got the drawn on bags under his eyes, and it's the wig is on half tilted and it's all messed up. And he's like, "What can I do for you, Mr. John?" Look, why you ring the bell again? And it's so on point for how we internally feel that we look on the outside, disheveled and night shift and huge bags under our eyes. It's just, if you can't laugh at it, we're going to cry, and we can't cry anymore. We have no more effort to cry anymore. So we do our best to laugh. If you ever need the darkest of jokes, come to an ER nurse or an ICU nurse or fire or EMS or the police, because we understand what humans really can be like. Anybody who works retail gets it, but not quite until you throw the medical portion of it in. Do you really see?
You throw that life and death thing in there.
Oh, it's not even life and death sometimes. Sometimes it's just a lot of drugs. And you just go, how is this dude flipping over, a row of chairs that weigh 120 pounds and you just flipping them like they're nothing? And I'm going, oh, that's meth. That's 100% meth.
That's right.
That's 100% meth.
Man, there's so many areas I still would love to explore. I have a quick question.
Sure.
Here in the United States, there's a lot of research that shows that people of color are getting a lesser medical treatment than white male, shall we say. Does free medical in Canada help heal that?
We're trying. You can't help sometimes implicit bias. And, if you've grown up in a household that tends to lean a little racist, you will then potentially carry that in. But, we're really trying. Me personally, I'm very aware of the fact when an African-American female comes in complaining of pain, their pain is, underreported. It's a lot of times not taken seriously. Their, death rates in childbirth are so much higher than a white female's. And, I'm very aware that there are huge disparities between those of color and those of not. And especially, just going to, again, health, the message of most of the medication side effects and all of these things, all the studies were done on males because they didn't want to throw in females because our hormones are all over the place. And it made the studies they weren't easy enough to kind of predict. So a lot of healthcare has been focused on men and their health and not on females. Like, female heart attacks present exceedingly differently than male heart attacks. It's not the clutching of the chest kind of thing. I had a woman, 77, come in and she was just complaining about like 2 out of 10 reflux. Huge heart attack, died 6 hours later.
Wow.
So real quick, just run a couple more of those down so that I can pay attention for my partner. What are some other things?
For heart attacks?
Yeah, for a woman.
Is it still the ICU nurse? She knows.
No, unfortunately, that didn't work out. I've been in another relationship for the last 10 years.
Okay. Kudos for surviving 20. I'm going to get so much.
Kudos to my ex-wife for surviving 20 with me.
Yes, also. So for women, it's more reflux feeling, more chest tightness. You're not going to get the arm involvement. You're not going to get the jaw involvement. Nausea is a big one, tiredness, just feeling generally unwell, and some short of breath, but not a ton. But really, they present completely opposite. And so Elizabeth Banks did something for, I think, the American Heart Society or the American Heart Society or something. And she portrayed like what a typical female heart attack looks like. And it was stunning to see the difference between, the guy clutching his chest and the arm pain and the jaw pain and into the back versus the females where it was just more reflux and very minor symptoms. And is that because we typically have a higher pain tolerance because of our chronic pain with periods? Who knows? Haven't done studies on it.
Thank you for your generosity. The other thing we haven't done studies on, which I think is criminal, is menopause.
Oh, we're getting there. We're so close.
Yeah, not even close. From where I sit, it's a drop in the bucket. We need a lot more resources to go into that because every woman faces it and nobody's telling them what it's like or what to expect and the impact to them. And it personally impacts me. And I see how we need to do a better job of that for the women in our life.
Yeah, there's a lot of work to do on the women's end. It's just because we weren't people, 100, 200 years ago.
Well, here's the other thing is I think that women's knowledge of healing and intuition was at some point in history labeled witchcraft and they were burned or or they were drowned, and then you knew they weren't a rich. But
Isn't that fun?
yeah, who came
It's
up
got
with
Salem
that?
written all over it. Yeah, I mean, the midwives, the healers, those were, the grandmothers who'd been around for at least 40, 50 years, who had all this wisdom passed down from their mother, and they helped the women of their tribe. And it wasn't until medicine and science kind of got their hands in to say, oh no, we need to birth in hospitals. We need to do it this way. And a woman needs to be on her back to birth. And, being an advocate of midwifery, but also, the hospital is my safe space. Yes, I had a midwife, but yes, I also had my babies in a hospital and took the epidurals.
Well, my ex had 3 children, and we had the same midwife for all 3. And what I was grateful for is the midwife was a strong advocate in the hospital for Liz, so that her wishes and desires, plus, as you well know, you work with your midwife through your whole pregnancy. It's not like you show up at a hospital as a stranger.
Yeah.
So
it's hard. So in Canada, I know, they're starting to support midwives. The funding is there. You don't have to pay for a midwife, that kind of thing. But when the midwife comes into hospital, there's a nurse assigned to that patient. Well, does the nurse need to be there if there's a midwife? And it's this weird dance, and everybody's a little different, and every midwife and every nurse is a little bit different. So there's a lot of friction sometimes, because the roles aren't really well defined as to what's happening. And then if you choose to have an epidural, you can still be under the care of the midwife, but if you have a complication, then you have to be under the care of the OB, but the midwife can still be there. There's a lot of overlap and a lot of overlay. And it's sometimes when people want very clear distinctions and lines, especially in pregnancy and childbirth, the lines are very hard to define.
Got it. Well, I hope your book comes out in all the right time.
Just in time for the holidays.
Just in time for the holidays. And my intuition tells me that it's going to be a banger.
Listen, the ongoing joke is if I ever need a new therapist, I hand them the book and they go, this is volume 1 of why I am the way I am.
Do your homework.
Do your homework. We're going to save me $5,000. You enjoy, you laugh, you cry, you learn a little things. Here you go. But they're actually, with this conference, there was a health system that reached out to me, and they want 6,000 books for their nurses for Nursing Week. So I'm waiting for the ink to dry and going for it. But it's one little step forward, and if I get along the way, I've got a half decently thick skin, but it's usually only the OR nurses that can.
Well, it's okay to get that as a pre-order, prepaid. Just let me. I'll tell you. Go ahead and close that deal. Strike. Yeah, go ahead. Get them to sign. Anyway, we have a tradition on this podcast of asking a question at the end.
Final
of the
question.
Uh-oh.
It's an important question for us. We treat it with the proper irreverence and also respect. So, without further ado, Eminem or Foo Fighters?
Oh, Eminem.
All right.
Hands down, love this guy. I've grown up with him. It's actually one of the one with the red carpet or the red curtains.
That's a brilliant.
Is one of my go-to if I'm having a shit day. It's on blast. Venom. Venom hits so hard as an ER nurse, and spinning it in your head, and I can't remember the lyrics, but man, they're just it hits so hard. I absolutely love him.
All right.
Beautiful. Thank you so much for your time and your insight today, and your frankness, your good humor. We're so grateful on behalf of humanity. We're so grateful.
Service.
Yeah.
Stop.
Let's bang some pots and pans. Yeah.
Fucking pots and pans. Thank you. I'll take it. Just feed your local ER. That's all I'm asking. Just if you have leftover food from any event, you don't know what to do with it, you take it to the local ER. No questions asked. Gone.
Recording stopped.